Well, good morning, everyone, or good evening. Thank you so much for the kind introduction. I was looking forward to this presentation since my last presentation, because it sort of builds on what I talked about before. Today, we're going to talk about temporomandibular joint osteoarthritis. My introduction tells you who I am and where I am. These are the obligatory pictures that everyone shows of where they live and where they work. As a disclaimer, I am a clinical consultant for Stryker TMJ Concepts. The objective of today's presentation is to provide you with an evidence-based information related to the pathophysiology, diagnosis, and management of temporomandibular joint osteoarthritis. And my presentation is mainly coming from a chapter that I was invited to prepare for this book, Contemporary Oral Medicine. Dr. Shelley Abramowitz from Emory University was my co-author. And so if you would like to refer to anything in my presentation, that this chapter does that. This is the outline that I will use for today's presentation. We'll talk about the definition, the epidemiology, signs and symptoms, how you make the diagnosis, and then using cases, I'll present the management of temporomandibular joint osteoarthritis, and then finish up with some future considerations and some of the research that we're involved in, both at Rush and University of Illinois. First of all, we have to classify osteoarthritic diseases. Osteoarthritis is a low inflammatory disorder as opposed to rheumatoid or metabolic or infectious arthritis, which are high inflammatory disorders of joints. So we're going to be talking about low inflammatory disorder, osteoarthritis, or degenerative joint disease. The definition is chronic degeneration of hard and soft tissue components of a joint, resulting in joint anatomy and mechanical alterations, leading to joint pain due to modification of peripheral and central pain processing mechanisms. This is a slide that I showed in my last presentation, but is germane to today's presentation. Normal joint put under normal function will adapt. What we're dealing with in osteoarthritis is maladaptation due to either microtrauma, parafunction, functional overload, or increased joint friction. This leads to dysfunctional remodeling and the formation of abnormal cartilage structures, leading to hypoxia in the joint, which we'll discuss further in a minute, and the development of pro-inflammatory cytokines, leading to cartilage breakdown and degenerative joint changes associated with osteoarthritis. Now, in order to prove that overloading leads to damage, this paper and one recently published by Almarza et al. From Pittsburgh shows that loading leads to condylar fibrocartilage damage. We also know, as I discussed in my previous presentation, that sustained inflammation is a predisposing factor to structural abnormalities within the joint. And that maladaptive response is a result of the results in the inflammatory cascade, leading to impaired cellular function, tissue damage, and synovitis, which reduces lubrication and nutrient supply to the fibrocartilage. This inflammatory cascade is shown here in this cartoon, and it leads to tissue destruction and impaired lubrication. So synovitis and the development of all of the alphabet soup of cytokines leads to degenerative changes that we see in any joint, including the temporomandibular joint. And recent research has shown that there are multiple signaling pathways that lead to cartilage degeneration. And so most of the work now is looking at how can we decrease the development of all of these cytokines that lead to cartilage degeneration. And this is a complex issue because this cartoon shows you all of the areas and all of the cytokines that lead to tissue destruction. And one of the projects that we're looking at now in our research is how can we stop the development of these cytokines? Is there a way? But you can see, you can stop one, but there are many, many of these that are associated with the development of osteoarthritis. So let's look at epidemiology. Joint pain is one of the most frequent causes of outpatient complaints among patients with chronic diseases, of all diseases. And if we look at all of the chronic problems that patients present with, you can see that degenerative joint disease is probably second to high blood pressure and diabetes. And if we look at this closely, we see that women have a higher incidence of osteoarthritis than men. Basically, this is because of the estrogen issue and its relationship to bone and osteopenia. If we look at the age distribution of low inflammatory arthritic disease, we can see it is a disease affecting patients in later life, as opposed to the high inflammatory diseases such as rheumatoid disease, which covers the spectrum of patients from the second decade all the way up to the 8th decade. So we're dealing with patients who have wear and tear on their joints. And it's said that 40% of the population over the age of 40 years of age have degenerative changes in their joints. Now, when we look at the temporomandibular joint pathology, about 11% of the patients had symptoms of TMJ osteoarthritis. But when we look at the whole spectrum of patients, minimal flattening of the condyle or eminence was seen in 35% of the TMJs in asymptomatic patients. Therefore, it's concluded that minimal flattening was probably of no significance. And this slide demonstrates that. This is an 80-some-year-old patient who presents for removal of some teeth. And when you look at the Penerex or orthopan tomogram, we see a flattening of the condyles. And if we question this patient and we ask him, do you have pain in your joints? Nope, never had a bit of pain. Okay, why is that? Because imaging may show us something like this, but they're not the determining factor of TMJ pain. It's the clinical symptoms that are important, because there's such a thing as primary osteoarthritis, which is characterized by the absence of any local or systemic factor. These patients don't have pain or they have minimal pain, as opposed to secondary osteoarthritis, which is associated with prior traumatic events or disease. These are the patients that we're interested in looking at. We'll talk about secondary osteoarthritis a little bit more. There are 4 stages to TMJ osteoarthritis. There's cartilage compression and chondromalacia, which is demonstrated nicely in arthroscopy. And this is due to overload of the joint. We have fibrillization and exposure of bone. Cartilage actually changes and fibrillizes. You can see that again nicely in arthroscopy. the disc and subarticular bone fails. We either get a hole in the disc or the disc displaces itself. Again, the result of the synovitis and the accumulation of the cytokines that we talked about earlier. And then in most patients, we can get end plate healing. Some of the patients do resolve, and we'll talk about that in a minute. So this is the classic picture in this cartoon of osteoarthritis, and it demonstrates a couple of things. One, the characteristic flattening of the condyle, the osteophyte that seems to develop as a result of that, and the flattening of the articular eminence. It also demonstrates the fact that the loading on the joint is not in the glenoid fossa, it's on the posterior slope of the articular eminence. And here's some images that we would see on a CBCT of the flattening that I demonstrated in the earlier imaging, but it also demonstrates in the anterior posterior view the lateral pole of the condyle flattening. This image demonstrates this collapse of the subcondylar bone, which looks like a cyst and is actually called Eli's cyst. And it demonstrates the failure of the subcondylar bone. Now, in orthopedics, they've developed a grading system for disease, osteoarthritic disease, in both the knee and the hip. Unfortunately, the only temporomandibular joint grading system we have. Oh, wait, we need to mute somebody. The only grading system that we have is the Mankin system, and this is only has only been used in animal research. So Shelley and I decided in our chapter that we would develop a grading system or a classification system for TMJ arthritis that would not only stage the disease, but provide us with the symptoms, the signs, what the imaging looks like, and then the management. And so we're gonna use this classification system for the rest of my presentation. So let's look at this a little closer. In early disease, we have joint pain, muscle pain, limitation of function, and some crepitus. There's little or no signs of an aesthetic or occlusal change in these patients. And the imaging looks like this. Okay, there's really minimal change. So we would use non-invasive or minimally invasive management options. And we'll discuss each one of these, as I said, as we go ahead. With arrested disease, we have some joint pain, we have muscle pain. And as we talked about last time, the muscle pain is the result of Hilton's law, that if you have something wrong with the joint, the muscles that move that joint are going to be painful in order to prevent further movement of that joint. You're going to have some dysfunction as a result of the muscle reaction to the joint pain, and we'll have increased crepitance. And we may see a patient with a class 2 malocclusion or an open bite. And we'll see further flattening of the condyle. And here we may end up using invasive methods, and we'll discuss those in a minute. We'll be talking more about the use of arthroscopic management, arthrocentesis, and viscosupplementation. And finally, we have advanced disease, where we have tremendous joint pain, much more muscle pain as a reaction to all of the cytokines in the synovitis. We have dysfunction, patient is having a hard time using the joint, and in many cases, particularly the bilateral cases, we'll see retrognathia. We'll have a high angle class 2 malocclusion, open bite, and potentially an ankylosis as this disease progresses. And so we end up with joints that look like this. In this case, the management option is salvage or joint replacement. So let's talk about management using this classification. But what are our goals? Our goals are to preserve or improve mandibular function and form, foremost, reduce disability, decrease pain. Notice I'm not saying take away all the pain. We're going to decrease their pain, and we're going to increase their quality of life by improving all of the above. So when we look at management, we have to start looking at the literature. What does the literature tell us? Well, this is a Cochrane report on what we know about osteoarthritis management. And unfortunately, the conclusion they come to is that in view of the paucity of any high-level evidence, we really don't know much about the management of osteoarthritis of the temporomandibular joint. And so they encourage more studies on this subject. So let's look using our classification system. Well, Hochberg developed a triangle of management for rheumatoid disease. And you start out with the simplest and you move to the most complex, which is the way we manage most things in our field. You start with the simplest and move to the more complex. Well, Shelley and I decided, let's build our own triangle based on Hochberg's work in the management of temporomandibular joint osteoarthritis. And we start with the simplest thing: education, physical therapy, orthotics, or oral appliances, and soft diet, and gradually move up the scale. And that's what we're going to talk about next: how we move up the scale and what works at each level based on the literature. So non-pharmacologic management options that we have, and I'm going to use the stoplight again as I did in my last presentation. Anything that has a green light on it means that there is good literature that supports its use. Anything with a red on it indicates there is no good evidence that it works. So you can see that if we educate the patient, explain to the patient what the disease process is and how we're going to manage it with them, and the importance of their buy-in to our management, this helps. Soft diet, certainly, you know, if you have a sprained knee or osteoarthritis in your knee or your ankle, you don't run the marathon. So if you have osteoarthritis of your temporomandibular joint, you don't chew gum and you don't eat hard objects. Physical therapy helps to develop a good range of motion and strengthens the muscles. And the oral orthotic will discuss its management, why it works. And low-level laser therapy has been a hot item in some places, definitely doesn't work. There's no literature that supports that. So let's look at physical therapy. Well, there's no specific physical therapy modality that seems to be the one that works the best. But the literature tells us that any non-invasive, reversible treatment is better than none. I have a colleague at one of the dental schools here in Chicago who's a physical therapist who's actually working on some guidelines for temporomandibular joint physical therapy, along with other physical therapists who have interest and expertise in this area. So, you know, we're looking forward for some guidelines for this. But physical therapy does work because it gets the muscles moving and increases range of motion in these patients. Complete coverage appliances are the things to be used, not partial coverage appliances or mandibular repositioning appliances. There's really, again, we want an oral orthotic that doesn't change the occlusion. And there's good evidence to support the use of these devices for the management of localized myalgia and arthralgia. And Dorit Nietzsche, who will be speaking to you in the future, did a very nice study using a flat appliance to reduce the force directed at the temporomandibular joint, therefore breaking the hypoxic reoxygenation cycle that I mentioned earlier, This study was a nice study that was done, and this actually does work. By opening the bite posteriorly 2 to 3 millimeters, you take the pressure off the loading zone at the posterior slope of the articular eminence and the anterior aspect of the condyle. This is exactly what's done in orthopedics with the use of crutches and canes in patients with osteoarthritic disease in the knee and the hip. As I said, their low-level laser therapy was proven to be no more effective than placebo. So, moving up the scale here, what about pharmacologic agents? Well, we know that acetaminophen works, non-steroidal anti-inflammatories, COX-2 inhibitors, non-acylated aspirin, and other oral medications. Opioid analgesics should be used very carefully in these patients. Again, the opioid crisis has shown us that we have to monitor these pharmacologic agents very closely. But what about glucosamine and bisphosphonates? Well, before we get to that, non-steroidal anti-inflammatories, we have to be very careful in the use of those drugs, because there are certain patients that have GI and cardiovascular risks associated with taking these types of drugs. So we have to be monitored these drugs very closely in these patients. What about glucosamine? There's been a lot of advertisement of this type of drug. It was shown that oral glucosamine sulfate is not superior to a placebo. So there's no real indications for the use of that drug. What about the bisphosphonates? There's no support for the use of this in orthopedics to manage osteoarthritis. So that's out. When we get to stage 2 disease, we can look at viscosupplementation, arthrocentesis, arthroscopy, and cell-based therapies. All of these are yellow, meaning that there really is no good literature that supports the use of any of these. So let's talk about them a little bit. What about cortical steroids? You know, everybody likes to inject cortical steroids into low inflammatory disease. This study showed that lavage was more effective for pain reduction than the use of either methylprednisolone or triamcinolone injected into the joint. And the problem with the injection of corticosteroids is that it can lead to the development of chondromalacia, which is one of the stages of osteoarthritis. And we've seen this in patients who have come to us with early onset osteoarthritis, who've been to a rheumatologist who's been injecting their joint with steroids. So you have to be very careful with the injection of steroids in patients' temporomandibular joints. Steve Milam did a really good study on this, showing that the amount of steroid we inject into a temporomandibular joint is probably 1 million times more than what we should be injecting. What about the use of platelet growth factors and hyaluronic acid and some of the other things? It showed that the combination of corticosteroid and hyaluronic acid is somewhat more effective than just either of them alone. Although it's been shown now in orthopedics that hyaluronic acid really only stays around the joint for a period of about 10 minutes because you're injecting it into a highly inflamed joint. It's picked up by the capillaries in the joint that are increased because of the inflammation, and it's washed out. They're inconsistent finding with the use of platelet-rich plasma in patients with osteoarthritis. There's been an interesting study done out of the Czech Republic where they've used either hyaluronic acid or platelet-rich plasma in patients before surgery in order to take some of the pain away as they prepare the patients for surgery. Arthrocentesis has been shown to reduce pain and increase function in patients, but after 26 weeks, both treatments modalities achieve comparable results as opposed to just doing nothing. So why do arthrocentesis and arthroscopy not deserve a green check mark? Mainly because all the studies have only use small sample sizes. They don't use any staging. You don't know what stage of osteoarthritis you're dealing with. There are a few male patients. They lack control groups. There's no accounting for the influence of the concomitant use of non-steroidal anti-inflammatories or the injection of steroids or viscosupplementation. And there's very, very short follow-up. So, until these kinds of studies are developed and produced in the literature, we're sort of wondering about the use of these. Now, arthroscopy is excellent as a diagnostic tool, but is it, a good therapeutic management option? And maybe Dr. Warburton can discuss this a little bit further. There have been inconsistent results with PRP and arthrocentesis, as I mentioned earlier. What about cell-based therapy? This is a hot item in orthopedics right now. And there was a whole symposium done out of the Mayo Clinic related to this. And what they concluded was that there's really an absence of specific and clear understanding of the use of these materials for therapeutic purposes. There's a hostile environment in osteoarthritic joints. All of the cytokines that are there, how do they interact with the injection of these cells or these cell-based therapies? We don't know. Many questions about cell-based therapies are called to question because we don't know the optimal cell source, the dosage, the injection time, or how often they should be injected. And finally, there's a lack of consistent approach in clinical trials. As I mentioned before, there's a whole bunch of problems with all the studies that have been done because there's no classification system, particularly for temporomandibular joint. What about discectomy? Well, in the late stages of osteoarthritis, where the disc either has a hole in it or has been completely displaced, it appears to be a reasonable approach. And we discussed this when we discussed the disc in my last presentation. So discectomy is an option. So let's look at some cases and using the classification system, how do we manage these patients? Let's look at early disease. These are the patients that have little occlusal changes, some occlusal changes, and we can use non-invasive methods. This is a lady who presented to us back in 2004, and her chief complaint was that she had developed an open bite on the right side. You can see that. And when we look at her imaging, you can see that she has developed a osteoarthritic change in her left temporomandibular joint. So she strikes her occlusion on the left side before she does on the right side. So we use this management option for stage 1 early disease. First, we want to find out from history whether this is primary or secondary disease. And as I said earlier, primary disease is something that just happens to everyone by overload, as opposed to secondary disease, which is the result of trauma or overload as a result of missing teeth, chewing on one side as opposed to the other. So we take a good history from this patient. This patient had no history of trauma, no history of unilateral chewing habits, or anything that would lead us to believe this was a secondary disease. She had all her teeth So that wasn't an issue. So the first thing we did was we removed or decreased the source of any overload on that side. So we gave her an oral appliance. In order to decrease her pain, we used time-contingent non-steroidal anti-inflammatory drugs. And by time-contingent, I mean the use of these drugs either twice a day if we're using something like Aleve, or 4 times a day if we're using something like ibuprofen. And the reason we give the drugs that way, and we tell the patients to take them that way, is that's the way they work pharmacodynamically. If you just take a drug when you have pain, okay, that's going to work on the next pain, as opposed to prophylactically taking the drug before the pain starts. And believe me, knowing what bone pain feels like, since I go through that on a daily basis with the bone disease that I have, I can tell you the time-contingent drugs do work, as opposed to just taking them when you have pain. In this patient, we talked about diet consistency control, where we tell the patient, don't chew on hard things. If you like carrots and celery, boil them, make them softer. So a softer diet. And then the use of heat or ice to control the muscle spasm that accompanies any disease, any synovitis that is associated with the joint. Again, going back to Hilton's law, that the muscles will react to anything that's wrong with the joint. And some patients like heat, some patients like ice. Both accomplish the same thing. Heat increases the blood supply quickly, ice increases the blood supply slowly. But it does increase blood supply eventually. That's why your face turns red when you put ice on it. It's an increase in vascularity. Tincture of time. The use of this technique does not happen instantly. So we give the patient 3 months. Okay, 3 months. And ultimately, 80% of the patients, if they follow this regimen, do well. 20% of the patients do not. And those are the patients that go on to joint replacement. So what happened to our patient? This is her 2 years later, having followed that regimen. And we look at the condyle, and it's flattened, but it's gone through the 4 stages that I talked about earlier, and she's now at end plate healing. And she's now in a good occlusion, bilateral. And we've seen this patient that my colleague, the orthodontist who did the oral orthotics, in this case, she had no orthodontics. The orthodontist was the management, managed the orthotic in her case, followed her and in his office, and she's done fine, and her occlusion has remained stable. So this is a patient with early onset disease that can be easily managed using the regimen that I talked about. And we followed a number of patients using this technique. I think this is about 20 patients. And we followed them over a period of about 4 years. And we can see, using these power diagrams, pain, function, and diet, they decreased using visual analog scale over time. Never got to 0. They still had some pain, but never got to 0. And their maximum incisal opening increased. So the temporomandibular joint has extensive adaptive, healing, and regenerative potential, as shown in this particular case, in early stage disease. What about when we get to late disease, either arrested disease that has gotten to the point where we now have a malocclusion, or the advanced stage disease where we end up with patients with open bite? These kinds of patients. Or we move up the scale. and we get to surgery. And these are the kinds of things that we've talked about using surgery. And again, we use the stoplight. We have to be very careful using arthroplasty, hemiarthroplasty with autogenous tissue, hemiarthroplasty using alloplastic material, hemiarthroplasty using bioengineered tissue, which is not yet available, orthognathic surgery, because when we do orthognathic surgery on these patients, we're adding another load, because typically what we're doing in these patients is a sagittal split osteotomy, repositioning the proximal segment into the fossa, adding increased loading to these cases, because we're doing an advancement, we're doing an auto rotation to close the open bite, so we're adding another level 3 load on the joint. Total joint replacement with autogenous tissue seems to be inappropriate because we're now taking a joint that doesn't like bone and we're adding bone to it. So I think total joint replacement with a costochondral graft in low inflammatory arthritic disease, certainly in high inflammatory arthritic disease, is not indicated. Total joint replacement with an alloplast is certainly an option. So let's look at some of these cases. Alloplastic hemiarthroplasty. This is placing a liner against a bone. This was abandoned in orthopedic surgery for younger patients with osteoarthritis. And in the temporomandibular joint, this was a fossa eminence device that is no longer available. And what we were seeing in these patients is, again, pitting bone against metal. This is what happens. So this is the fossa, and this is what's left of the condyle in these patients. So this doesn't make any sense at all, and is abandoned, has been abandoned, because you can't get these devices anymore. This leads us to total joint replacement with an alloplast. And I've shown this slide before, that the practice of modern orthopedic surgery would be unthinkable without the availability of alloplastic replacement devices. And certainly this should be the same thing in maxillofacial surgery. So John Charnley, who's from Dr. Warburton's hometown in Manchester, England, is the one who has developed the joint replacement, alloplastic joint replacement in orthopedics back in the 60s. And so just like orthopedics, we can replace all of these joints. We should be able to replace the temporomandibular joint when it has end-stage osteoarthritic disease. So here's an example of a patient with end-stage osteoarthritis. You can see in the imaging, the flattening, the loss of contour, the Eli cyst, clinically the open bite, and on the imaging, the open bite. Total joint replacement bilaterally, nice closed bite that continues to maintain and is very stable. Does this stuff work? Yep, absolutely. This is a 20-year study that we completed on patients of mine and Dr. Wolford's, where we had a significant decrease in pain in these patients, significant increase in function, and significant increase in diet consistency. And certainly a significant increase in maximal incised opening. But more importantly, as I said earlier, one of the things that we were looking for in our management of these patients is an increase in the patient's quality of life, despite the fact that many of these patients in that 86% group still had some pain. They said their quality of life had increased. And that's the most important thing. And that's the thing I think we're looking at more now in everything that we do, from dental implants all the way to alloplastic joint replacement. So what's the future? Where should we be going with this? Well, as I said earlier, we need better osteoarthritis, TMJ osteoarthritis, random clinical trials using viscosupplementation, using arthrocentesis, using arthroscopy. Should we be shaving these joints down? What should we be doing? We just don't have good literature to support a lot of the things we do other than total joint replacement. We need good local and systemic cartilage degradation markers for TMJ osteoarthritis. As I showed you in that one slide, there are many, many markers available, and they're looked at very closely in orthopedics. But shouldn't we be looking at these in the temporomandibular joint? And this is one of the things, or of the many things that we're doing at both Rush and UIC with our colleagues, and I'll mention them in a couple minutes. What's the role for? What is the role of the local cytokines? As I showed you, there are a number of cytokines, and a number of ways these cytokines get developed in the joint. We need to look at those. What's the role of bioengineered tissue in the surgical management of TMJ osteoarthritis? I don't know that there really is much of a role for this, because the same problem is going to occur with bioengineered tissue as occurs with autogenous tissue that's used to replace joints, particularly when we're dealing with high inflammatory disease. When we're dealing with low inflammatory disease, it's still inflammation. There's still these cytokines that are around. There's still the MMPs. There's still M2 macrophages that are around that can affect bioengineered tissue. So I don't know what the role is for bioengineered tissue in these cases. And finally, what's the relationship between disc displacement and inflammation in the TMJ, leading to osteoarthritis? And to me, this is a chicken and egg phenomenon. What comes first? Is it disc displacement, or is it osteoarthritis that causes the disc to displace in osteoarthritic disease? This is a study that was done looking at the similarities between the differences in estrogen in regulation of temporomandibular joint and osteoarthritis in the knee. And this says, as I started out by saying, that the synovium plays an important role in the development of osteoarthritis, and that there are specific pathways and molecular mechanisms that need further exploration. This paper tells us that there's serious doubt exists about the significance of disposition in joint pathology. As I said in my previous lecture, disc function is more important than disc position. The disc is displaced in internal derangement as the result of that cascade of inflammation that occurs in the joint as the result of the development of cytokines due to overload of the joint. So my feeling is that disc displacement is the result of the synovitis that develops in the joint in the early stages of osteoarthritic disease, and that the disc displaces because of the effect of these cytokines on the elastic tissue in the posterior attachment. These are my colleagues, both at the University of Illinois and at Rush. And these are some of the studies that we've done looking at osteoarthritis of the temporomandibular joint. And we have a number of other studies, mainly done on mice that are looking at the pathways that lead to the development of the cytokines that we've talked about, as well as ways of potentially blocking those cytokines. So again, I'll end with this slide that I use a lot because I think it's important, because research is so important in every aspect of what we do, whether it's, again, dental implants all the way to joint replacement. The arrogance of success is to think what you did yesterday will be sufficient for tomorrow. So I want to thank you all for the invitation to speak here today, for your attention as we speak, and for the privilege of the time that you've taken to listen to what we have to say. So I'll turn this back over to our host, and we will answer any questions. And Dr. Warburton, I'd love to hear your comments and your expertise and experience in the field of the management of temporomandibular joint osteoarthritis.
Thank you so much, Dr. Mercuri, for your excellent presentation. I'm sure our audiences are enthralled, as well as they have really learned quite a bit. Let's wait for the questions. In the meanwhile, Dr. Warburton, the floor is all yours. Please share your views on the same.
Good morning, or good afternoon, or good evening, depending on where you are in the world. Lou, thank you for such a comprehensive presentation. We often, as surgeons, have tunnel vision and focus more on the surgical aspects of the management of degenerative joint disease. What you've highlighted is the importance and success of medical management, more conservative techniques in the earlier stages. Do I have the ability to share my screen? Let's see.
You do.
Okay, great. So Dr. Mercuri went through a lot of the inflammatory aspects of osteoarthritis. And in the early days, it was really just considered to be a condition due to wear and tear, overload of the joint. But what he's pointed out is that that is a part, but it's also influenced by external factors, and not only just affecting the bone, but affecting the cartilage and, importantly, the synovial lining. And now we're getting.
I can't see Gary's screen.
I'm going to share it in 1 second.
Oh,
there we go. Yeah. So what I came across is this paper that I thought I'd share with you, and we'd walk through a little bit. This is a summary, if you like, of all the published research that was on the topic of osteoarthritis between 2019 and 20, the Osteoarthritis Research Society International World Congress meetings. And it looked at the field of osteoarthritis and highlighted the publications that were in relation to osteoarthritis, the cartilage, the subchondral bone, and the synovium. And what was interesting in this, in addition to the therapeutic interventions that Lou mentioned, there are some novel areas of research interest that may be emerging. So I thought it may be worth sharing this and walking through it a little bit. So, for example, they discussed or looked at novel insights into the inflammatory changes. There's several noteworthy publications emerging on the role of macrophages in healthy and osteoarthritic joints, the application of mesenchymal stem cell treatments, and other significant treatments. This is interesting, the role of metformin, the anti-diabetic medication, which is being shown to enhance autophagy, which is clearing out of damaged or dead cells to alleviate osteoarthritis. So as Lou mentioned, you know, osteoarthritis is a low-grade inflammation, and it's characterized by synovitis, a pro-catabolic state of chondrocytes, and using a single mass cytometry, they identified 20 different chondrocyte cultures or clusters, pro-inflammatory and anti-inflammatory, and the inflammation amplifying cluster or population was consistently increased in osteoarthritic patients. And here are some of the inflammatory cytokines or genetic cell signaling pathway changes that occurred. And then, so down here now, low-grade synovitis is mainly characterized by activation of innate immune effector cells in which macrophages have emerged as the key dysregulatory cell. Lou did touch on that when he mentioned the M2 macrophages. So interventions that influence the maturation or the activity of macrophages may emerge as another therapeutic intervention for osteoarthritis. Mesenchymal stem cells, as Lou mentioned, there's been varying success published in the literature. There are different sources of stem cells. The adipose-derived stromal stem cells are easier to harvest than the bone marrow stem cells, traditional MSCs, and they do share similar properties to the MSCs. I now move down to the interesting one of metformin, which is an interesting and novel therapeutic modality. Over the last year, between 2019 and 2020, there are several research groups that published their results on the possible protective effects of metformin in OA development. And so how might metformin play a role in bone metabolism and osteoarthritis? Well, there's activation of the nutrient sensor adenosine monophosphate activated protein kinase, and reduction of this activation was observed in mouse and human osteoarthritic chondrocytes. And so this activity has been shown to counteract the cartilage degeneration that occurs under these low-grade inflammatory conditions such as osteoarthritis. And this group who published here in that same year showed that metformin coupled with COX-2 inhibitors had a greater role or increased benefit in osteoarthritic patients. So I thought that was an interesting paper to show. And then this is another final component to this, the microbiome in the GI tract. This has been shown in several studies now to play a role because in obese patients, the flora within the GI tract changes. There's increased levels of lipopolysaccharide in obese individuals. And this correlated with macrophage infiltration into joint tissues with pain scores and radiographic features of osteoarthritis. So I thought I would just share that as an additional paper of some potential novel therapies that may be coming here. And I'm going to stop my screen share now. So are there any questions from the audience on the medical management before we move on to discussing the surgical aspects?
Until we wait, I have jotted down some questions. May I bring them out?
Certainly.
I wanted to know when Dr. Mercuri spoke about use of orthotics, for how long generally orthotics can be carried on? You know, I mean, do you have to use them forever till the patient has pain, or because so many times patients ask us, Madam, for how long should we use this orthotic?
As I said, in my, let me get my ugly face on here. As I said in my presentation, for the early stage disease, 3 months was the time to use the orthotic. After 3 months, if we're getting success with the management with that management option, I have the patients only wear the orthotic at night when they sleep. If I have no success or the patient hasn't cooperated, we go to surgery, and then there's no need for the orthotic after that. So 3 months. Actually, you know, to extend that thought a little further, my experience with orthotics, whether it's just in a TMD patient with muscular TMD as opposed to intra-articular TMD, I found that I have to give the patients 3 months with the orthotic. You know, patients will come back after a week and say it's not working. Well, yeah, it's not going to work in a week. You know, so you know, And then unfortunately, we don't have any literature that supports this 3-month option. It just seems to be something that seemed to work. And so 3 months.
And sir, do you prefer soft orthotics or the hard ones? Especially,
Well,
and do
again,
you have different orthotics for TMDs? That means the internal derangement, and a different harder one for osteoarthritis. Would you like to separate that, or it's the same orthotic?
same. It's the same. It's a hard one,
Hard one.
flat plane. It has opens the bite posteriorly, 2 to 3 millimeters, again, depending on the occlusion. And again, depending on the occlusion, either cuspid rise or group function, depending on, again, the occlusion. The thing I don't like about the soft splints or orthotics is the fact that if you have a patient who has either a bruxing or clenching habit, it tends to make it worse. I know my dentist recommended I wear an orthotic because I clench, and she said, go ahead and just buy one off the shelf out. And so I bought one of the soft ones. I came home, and within 4 hours of working at my computer, I had chewed completely through it.
Okay.
So she made me a hard one, and I can't chew through that.
Which is more uncomfortable probably. The soft ones are like you get used to them so easily.
Yeah, they seem to promote more chewing.
Yeah, I agree with that. I think in my practice, the conservative treatment attempt is about 3 to 4 months, and then reevaluate, and then at that point determine, well, do we need to go up to the next level on the pyramid of surgical intervention? And I feel the same way about the orthotics. A large percentage of parafunctional patients, parafunctional habits are exacerbated with the soft appliances because they treat it like chewing gum, and it's doing the exact opposite. So I think a hard full coverage appliance is the best option with the most evidence in the literature. Partial coverage appliances, there's very little evidence in the literature, and they should only be used for short term. And when I say short term, I would say certainly no more than 3 months, because they can induce dental compensations with over-eruption of the teeth that are not in occlusion and intrusion of the teeth that are in occlusion onto those acrylic devices. Any other questions on the non-surgical management?
I wanted to ask you, if it is a pure internal derangement versus osteoarthritis, the choice of NSAIDs, will it differ? Because in internal derangement, the quality of pain and how it responds to NSAIDs, indomethacin versus celecoxib, do you feel there's a difference, or anything would do anywhere? The only thing that we have to keep in check is the cerebrovascular and gastrointestinal impact of the medication. Any thoughts on that?
You asking me or Barry?
Both of you, sir, one by one. Dr. Mercuri. Yeah.
Yeah, I mean, the non-steroidal anti-inflammatories, I don't particularly care which ones the patients use. What I care more about is the dosage and the time contingency. And again, depending on the drug and the dosage schedule, that's what I would use. And also I take into consideration the patient's GI and cardiovascular history, because those drugs, no matter whether you take them twice a day or 4 times a day, are going to have an effect on not only the heart and the liver, but also the kidneys. So you have to be very careful with those drugs. But again, the 3-month thing with the low inflammatory and stage 1 patient, I have no problem with them taking whatever drug they feel most comfortable with. As long as they follow the dosage schedule.
Exactly. I was going to say, Lou, is that one of the differences between the NSAIDs is the dosing intervals, right? And I think, taking into account the fact of the patient's risk factors, medical comorbidities, with the dose interval, that really steers which drug a patient might choose and which one you recommend. One other drug that I think Lou did touch on in his lecture, and that's very relevant in osteoarthritis, is duloxetine. Lou, what are your thoughts on the role of duloxetine, and when might you want to consider that?
I've never used it, so you might want to talk about that.
So I think in my practice, if patients are in chronic pain, there are changes within the central nervous system through the process of central sensitization. And so that influences the pain pathways. And duloxetine or Cymbalta is typically used as an antidepressant, but it's very effective in chronic pain patients. So if you have an osteoarthritis patient that's in chronic pain, then duloxetine may well be a useful tool in your toolbox.
Yeah, I used I think of the name of it, antidepressant.
Fluoxetine, sir, fluoxetine, the Fludac, the most famous one. It's in the same category, right? SSRI.
Yeah.
Yeah.
Yeah. Any of those drugs in low dosage. The problem I found with some of those drugs was many of the patients, because they were female, were concerned about the weight gain. Some of them were concerned about the palpitations that they were having with their heart. And I had one patient who came back and complained about the fact that she was exuding a green substance from her breasts. So I looked it up in the PDR and found that one of the potential side effects of these drugs was the exudation of something from the breasts. That was a very unusual complication. But most of the patients, it was weight gain that they didn't like with it, but it does work. The antidepressants do work in chronic pain patients.
So there's one thought, because the other day when I was doing my literature review for this, and I had a patient, she was on antidepressants with bruxism. Now my research said that there are certain antidepressants which increase bruxism. Would you like to comment on that? Dr. Warburton, do you have any thoughts on that?
Yeah, so I'm not sure about the antidepressants, but certainly the antipsychotics, they can certainly increase parafunctional habits and create dystonic activity within muscles, for sure. I'm not aware of a difference between the different antidepressant medications in terms of parafunctional activity. I'm not sure if Lou is.
I agree that the antipsychotics are certainly the ones to avoid in patients that are bruxism. But I'm unfamiliar with any information on antidepressants.
All right, well, shall we move on to talking about some surgical options?
There are a couple of questions here, Dr. Warburton. Can we take a couple of questions which have come here?
Certainly. Yeah.
Somebody would like to know, Dr. Anish Purna would like to know about the use of pregabalin in pain management. Is there any role of pregabalin in pain management here?
Yes, I think there is. We use gabapentin in chronic pain patients, and it is helpful and effective. That's more commonly used for the neuropathic type pains, but it does have a role in chronic pain management, yes.
What are your thoughts on role of neuroplasticity in chronic degenerative disease and CRPS syndrome? This question is by Dr. Varun Kashyap. Neuroplasticity in chronic degenerative disease, CRPS syndrome.
Yeah, so I think I touched on that when I was mentioning duloxetine, because there are certainly in chronic pain patients changes within the central nervous system, central sensitization, and that's through the process of neuroplasticity. That's the process by which the nervous system changes. But it's the central sensitization as a result of that change that predisposes people to chronic pain, and the duloxetine, antidepressant medications, they're effective in the management of that.
Yeah, and there's some, I think I mentioned it in my last presentation, there's been some really good work done in Germany as well as in Australia on the fact that there are neuroplastic changes associated with muscle pain. And that many of these patients who have muscular temporomandibular joint disorders have developed a central sensitization via the muscular neuroplasticity that has occurred as well. And that's why many of those patients, or some of those patients, I shouldn't say many, some of those patients with muscular TMD never seem to get better. And even with Botox, they don't seem to do well. So that whole area is an interesting area of research that I think we need to be thinking about. And certainly some of these drugs that have helped the neuroplasticity associated with chronic joint pain may also be helpful in dealing with the chronic muscular pain that we see in those patients.
There are a couple of more questions coming. Dr. Vahanwala would like to know any specific treatment for the orofacial dystonia or dyskinesia that you would like to suggest or you're aware of. Orofacial dystonia.
So for those patients, I will typically refer out to my non-surgical specialist. That sounds like a cop-out answer, right? But it's not a field of my expertise, because many of these patients are on that medication for a reason. And so if it's possible to change it in consultation with their primary care physician, then and avoid a drug with that side effect, that's helpful. What I've also seen my non-surgical colleagues do is Botox injections to try to reduce that. But that's the extent of my knowledge on it.
And most of those patients that we've seen have been the result of antipsychotic drugs. And I'm not an expert in that area, so I agree with Dr. Warburton. Go back to their primary physician. So that's one group of patients. Then you have the idiopathic dystonia patients. Again, that's not my area of expertise, and they get referred to the neurology.
I have a question here, sir. And idiopathic condylar resorption and osteoarthritis of the TM joint. At what stage would you start differentiating these two diagnostically? I know it's a little tricky.
Well, we've written a lot on idiopathic condylar resorption, and my feeling, and this again is a feeling. I don't have any data on this. Is that I think this is a form of JIA. It's in the spectrum of JIA, despite the fact that many of these patients, and we test every one of them for arthritic, high inflammatory arthritic disease, only about 85% of the patients who have arthritic disease will respond to the testing positively. But I believe it's a form of JIA.
There's
I
one.
think the thing that I would add there, from my perspective, is the difference between OA and idiopathic condylar resorption is age primarily. Osteoarthritic conditions are, as Lou mentioned in his demographic slide, they occur much later in life, 40, 50, 60 plus. Idiopathic condylar resorption we will commonly see in younger age groups, teenagers, and as Lou mentioned, it's a diagnosis of exclusion. You have to rule out all other causes of condylar resorption, which includes your autoimmune serology panel, rheumatoid factor, anti-citrullinated peptide antibody, ANA, all of that panel to rule out all of the autoimmune conditions. And then once excluded, then you've arrived at the diagnosis of idiopathic condylar resorption.
I want to, for the clearance of the basics, you have been comparing the complete osteoarthritis of temporomandibular joint with the knee, but the cartilage is different. We have at one place we have hyaline cartilage and at the other fibrocartilage. This difference in cartilage, how does the pathophysiology of OA in TMJ, responds to this different cartilage in both the systems? Would you like to say something on this, sir?
Well, the only reason that we have fibrocartilage in the temporomandibular joint as opposed to hyaline cartilage is if you look at the histology of hyaline cartilage as opposed to fibrocartilage, and you look at the load delivered, the constant load that's delivered to the TM joint would not tolerate hyaline cartilage. So it's an issue of function of the joint. And there are two other areas in the body that have fibrocartilage where there's a lot of activity. It's at the costochondral junction because you breathe so much. In the temporomandibular joint, you have a lot of activity just in swallowing. You swallow over 3,000 times a day and you move the joint. It's interesting, we're looking at now, is there a paper somewhere that talks about how many times you chew every day and what is the load delivered with chewing? We don't know that. So in our studies, we're saying that fibrocartilage is basically cartilage. And so what happens in the temporomandibular joint to the cartilage is the same thing that happens in the knee. It's the same thing that happens in the hip, every other joint that has hyaline cartilage. So to us, there's no difference. But the difference, histologically is the amount of collagen, type 2 collagen as opposed to type 3 collagen. But collagen is going to get affected by the cytokines, whether it's type 2 or type 3.
Dr. Warburton, any comments?
Only the fact that we know from studies years ago that fibrocartilage has the two advantages. It's not as susceptible to degeneration for the reasons that Lou just pointed out, the different collagen structures within it. And it also has a greater regenerative capacity compared to hyaline cartilage. That doesn't shield it from these inflammatory conditions because it will get destroyed just like hyaline cartilage.
Thank you so much. We have a couple of last questions before we move on to the surgical management on conservative. Dr. Tarang and Dr. Monish would like to ask the use of intra-articular injections in osteoarthritis in TMJ, the medications and PRP, role of PRP.
Well, as I said in my presentation, there are no really good studies that demonstrate that PRP works. And the reason is we don't have good classification in those articles that tell us at what stage they're using the PRP. Is it stage 1? Is it stage 2? Is it stage 3? And there are no long-term studies. So we just don't have any data to demonstrate that.
But so you did mention that hyaluronic acid does have some effectivity, right?
Yeah, the combination of
along with corticosteroid.
Corticosteroid. The problem with the hyaline cartilage is that the HA is that it dissipates rather quickly and has gone almost totally out of favor in orthopedics because of it. It's gone in 10 minutes. So, it fills the joint space, does some things, and then goes away because the joint is inflamed.
But so in that case, if we do the arthrocentesis first and do the lavage and then wait for some time and then give AHA, do you think it might have a better penetration or role? You think that could be?
No, because it's an inflammatory response, and you're in the joint. So, that's why people do it at the same time rather than going back. I'm not aware of any studies that have done what you suggested.
I was just sharing my thought. So yes, I think we are done with all the questions, and that was wonderful session on conservative management. Let's move on to the surgical management now, Dr. Warburton.
Okay, so we can kind of divide the surgical management into the minimally invasive techniques, intermediate techniques, open joint surgery, discectomy, and then finally for end stage disease, salvage with total joint replacement with alloplastic devices. That's sort of my surgical pyramid. We just looked at our outcomes of discectomy after a failed arthroscopy or arthrocentesis. And what we learned is it's not as effective as what Frank Dolwick and Dorit Nitzen published when that was the first surgical intervention, because they were reporting success rates in the 80% range. In our series at the University of Maryland, it was actually about 57% effective after a failed arthroscopy. And I know that Andrew Sidebottom in the UK has a similar experience with his patients, and he reported around a 60% effectiveness rate. So I'm not sure why that is, but discectomy after a failed arthroscopy is almost like flipping a coin. I think that arthroscopy has a role for sure in the intermediate stage 2 disease. My personal feeling is even in the later stages where you've got a lot of fibrous arthrosis, in other words, the joint space is obliterated with adhesions and fibrous tissue. If you can recreate a space using arthroscopic techniques and restore the ability of synovial fluid to reach the areas of the joint that are don't have a primary vascularity, such as the disc, then you're eliminating that hypoxia reaction and the subsequent cytokine cascade. And I've seen patients, even with awful looking joints, on arthroscopy with perforations, flattened condylar heads, even those with completely eroded fibrocartilage and exposure of the underlying bone, which you can see arthroscopically. Oftentimes those patients will do well. So even in the later stage, I personally, in my practice, would still offer them an arthroscopy first before jumping to joint replacement. We certainly need to be mindful of avoiding multiple open joint surgeries, because we know now from past experience that patients who have multiple open surgical interventions don't do well in terms of pain and functional outcomes. So that's my thoughts on the role of arthroscopy. I would also include it in the later stage disease as well, as opposed to going straight to joint replacement. Lou, what are your comments? I think you discussed it pretty well in your presentation.
Yeah, my only concerns, I think arthroscopy is a great diagnostic tool, particularly looking at the staging of arthritic disease. I don't think it hurts anything to go in and irrigate things out. If you want to instill a little bit of cortical steroid one time, I think that's a reasonable approach. I think the idea of taking away some of the fibrillization that occurs if you're a good level 2, 3 arthroscopist is a reasonable approach. I think it's certainly a way to make patients feel a little bit better in terms of pain relief, because it's not an open procedure. And as you said, doing an open procedure like an arthroplasty only adds to the problem, adds another surgery. And we know that the more surgery that's done on the joint before a total joint replacement, the worse the outcome. So yeah, I think it's a reasonable approach. I'm not so sure it's my own personal opinion. I'm not so sure it's a final management option for many patients with stage 3 disease. Talking about where they have an open bite and they have the condyles almost destroyed. So, I I sort of take the orthopedic approach to osteoarthritic disease. If I'm in late stage 2 or stage 3, I'm going directly to a joint replacement rather than putting the patient through anything else. Because, as I'm sure you're going to say, you know, we've had such good results with joint replacement in these patients that, you know, why bother doing anything else?
Are there any questions regarding arthroscopy or minimally invasive techniques?
Dr. Monge had taken a very interesting session on arthroscopy a couple of sessions back, which was shared with Dr. Sidebottom as well. And that's when Dr. Mercuri was also there, I think. And that whole aspect was very well discussed. And but in relationship with osteoarthritis of the temporomandibular joint, I think the role of arthroscopy was unclear until now, which I think I'm sure all of us now realize that level 2 and 3 arthroscopy is something that is very helpful, even in case of OA. Am I right when I say that?
Yes, I think so. For a portion of patients, yes, it can avoid the leap to a joint replacement. So
Can you tell me something in case of arthrocentesis versus arthroscopy? Because there are a lot of us who are doing arthrocentesis, but you know, arthroscopy is something that is a skill which we have to really work on and go into what is the, you know, level of success between the two? Do you think we can pull on with arthrocentesis and just because we're not aware, or do you think that arthroscopy is something that we should all try and learn? Minimally invasive surgery is something that is the way forward in order to be handling our TMD patients to give complete justice. What are you?
So I think there are many studies that show arthrocentesis and arthroscopy to be equivalent in terms of pain and functional outcomes. There are some studies that show a slight advantage in arthroscopy. I think the big differentiating factor is what Dr. Mercuri said is a diagnostic value. Arthrocentesis is blind, and it's not 100% success rates. It depends on the study that you read. It's in the ballpark of 80 to 90% success rate. So you're going to have 10 to 20% of your patients come back with continued symptoms. If you haven't looked inside the joint and you've just done an arthrocentesis, you really don't have any further information on which to base your decision on the next phase of intervention. So that's why I have abandoned arthrocentesis and I just do arthroscopy, because it gives me that additional diagnostic information. And you can also do biopsies. So let's say you suspect a patient has a rheumatoid or a high inflammatory condition of the joint, take synovial biopsies, and that can confirm it.
Dr. Mercuri, any comments on that? Arthrocentesis versus arthroscopy?
Yeah, I agree 100% with Dr. Warburton and what he says. What I would love to see are studies that differentiate patients based on the classification system. You know, we're doing better with internal derangement studies. Patients are using Wilks classification, reporters are using Wilks classification when they report their success rates. So I think that's helped us in that regard. I think what we need is to establish a classification system for osteoarthritic disease. And as we report our results with arthrocentesis, arthroscopy, joint replacement, whatever technique we're using, report them with that, you know, X number of patients are stage 1, X number of patients are stage 2, on and on and on and on. That little study that I showed of the stage 1 patients, it was like 20 patients. Those were all stage 1 patients. So, I mean, that study is, you know, fine, but we need more and more we need more than 20 patients to say that technique works. So that's what I think we need to have in order for us to be able to say with some confidence that if we use arthrocentesis, we're just irrigating is going to work. If we start adding things to it, like orthotics and physical therapy, non-steroidal anti-inflammatories, HA, whatever we're injecting, then we don't know what's the results. We need RCTs.
So shall we move on to a short time on total joint replacement before we run out of time? So I would just start this section with the overview of stock versus custom joints. And I think there's now the majority of surgeons, I think in one recent paper, it was 75% of surgeons would prefer placement of a custom joint. It's easier surgically, shorter surgical time, and can be used in more severely abnormal cases with anatomy that's been completely destroyed by either trauma, tumors, or just degenerative process. So I think custom joints are favored more now than what they were in the past. One topic that I know Dr. Mercuri and I do want to bring up here to make people aware of is around the world, there are so many different devices that are made in 40 countries. I think there are, what was it, Lou, was it something like 20 countries, 40 different devices, something like that. Some of these are 3D printed, some are wrought and milled, and there's a difference. And I know Dr. Mercuri has done a lot of research at Rush looking at the different grain structures with the printed titanium compared to wrought, looking at the alpha and the beta phase. So I'm hopeful that he can give a little summary as to what the differences are. There are other problems with the printed devices that people need to be aware of is porosity and density, because they can lead to weak areas and predispose to fracture. So I think, with the devices that are being produced around the world, number one, few of them have undergone any regulatory testing. They don't have a track record. And now we're introducing the 3D printed devices, which is a whole new variable with a lot of potential problems. So I just want people to be aware of what these restrictions and potential concerns are. Lou, would you like to make some additional comments?
Yeah, I think that's a really important point that you make. The issue with alloplastic devices, both in orthopedics and in TMJ, is that companies are trying to make these devices cheaper to produce on their end and make them faster. And 3D printing, really works well if you're dealing with plastics. Plastic 3D print, I mean, you can print stents for your orthodontic surgery on your home computer. I mean, there's nothing to it. But once you get to metals, it's a whole other issue because there's a lot of technology that still has to be developed in order to print accurately metal devices. And the thing we're studying the most now at Rush is, as Dr. Warburton says, what's happening to the metal as it's 3D printed in terms of porosity. And what we're finding is that the devices, the TMJ devices that we've gotten so far and looked at have tremendous porosity, which has led to all of them breaking. And that's how we ended up getting them. So just because it's faster and cheaper to make something doesn't mean that it's better at this point. We've also seen this with the orthopedic devices, particularly spine cages, where the spine cages, some of the spine cages we've gotten have broken as the surgeon is inserting them. As he's putting the screws in, the screw holes break because the device is so porous. porosity is good because you're going to get ingrowth of bone, but it's not good if you're going to load the device. So that's important. The second thing that Dr. Warburton brought up is, I think, even more important, is that a lot of these devices have gotten out onto the market in the various countries, and there's no regulation. I mean, here in the United States, it's very difficult to get a device on the market because of the restrictions the FDA puts on them. But in some of these countries, there are no restrictions. And there are no clinical studies on these devices. If I read a paper from a certain country about a device, they've put one of the devices in, and now they write a paper with 6 months follow-up. You know, I mean, you need, in this country, you need 3 to 5 years follow-up on a device before the FDA will accept it. So, you know, be very careful of these devices. And I know the problem in countries like India and many other countries around the world is that the cost of the 2 American devices that are approved by the FDA is very expensive because they have to go through agency and all of that. But you know, what our concern is that these devices, as they fail, are going to put a bad name on the whole idea of alloplastic joint replacement, and they're going to get us back to the Proplast Teflon issue that we had before. So our research is more interested in, you know, showing the problem to surgeons and why surgeons should understand this problem, because like a drug, you know, you wouldn't prescribe a drug for a patient unless you knew what happened to that drug in the patient's body. Okay? So the same thing with joint replacement devices, either orthopedic or TMJ, you shouldn't be putting them in a patient's body unless you know what's going to happen to that. Not only from the standpoint of the metal itself, but with function, this metal is now going to shed particles as well as metal ions. And those ions go to other places in the body and have an effect, particularly when you're talking about cobalt. So, I mean, there's a whole lot of issues related to this. And I'm sorry for going on and on about it, but this is our area of study right now and our area of interest.
No, Dr. Mercuri, what you have mentioned is extremely important. And in fact, that is the reason why TK Live is there, because of the potential for causing harm as surgeons. And now availability of technology like 3D printing, which is so easy and cheap. These kind of things are happening very often and very easily. And I think we are all thinking that we can all do TJRs without taking responsibility of what happens next. So what you have said and this whole conversation and discussion is extremely pertinent to the times that we are in, because currently this technology has just entered into Indian market and it is booming. It's there everywhere and everybody has a lot of curiosity and they all wants to try their hands on it, but they trying is on their patients, and which is what and in India we don't have regulations. That is the biggest problem. So the only regulation is our own knowledge, our own information, and our own motivation to do no harm. And that is the reason why this whole conversation and discussion becomes extremely important. Thank you so much, everyone. I hope all your questions were answered. And can we wind up? Are we ready? There's one last question. There's one last question. Any study on custom-made TJR release of metal in the body?
Pardon? Say that again.
Yeah.
Are there any studies on custom-made TJRs release of metal in the body? Metal ions in the body. Are there any studies which?
Yeah, we published the study in JOMS on that. And there are a couple of other studies that I've seen that have, discussed it as well. In fact, one came from your country as well. So, yeah, there are studies on that. And what we're seeing is what we expected. There's a release of metal ions that are picked up in the blood. Fortunately, they haven't reached the range that is of concern. You need somewhere between 2 and 20 parts per billion of cobalt before you become concerned. And we haven't reached that level, at least in the pilot studies that we've done. The problem with these studies is that they're extremely expensive to do, because to run each blood sample through the machine is almost $500. So you need a big grant to be able to do that study properly. But we did a pilot, and it's in JOMS if you look it up.
I have one last question. What about metal allergy? We don't even know that the patient is allergic to metal, and we have put it in. And
You got about 5 hours.
Yeah, I was going to say that's a whole topic in of itself.
That's a whole topic. I mean,
all
So,
right.
I mean,
All
I'm
right.
happy to.
That's another
try and
complication
distill it.
waiting. Yes.
I'm happy to try and distill it into like 2 minutes. We know now that skin patch testing is not an appropriate test. It's testing the wrong cell. We then move to lymphocyte transformation test because it's testing the correct cell that's around the deeper tissues around a joint prosthesis. Orthopedic literature emerged last year in July. One study in particular, and I've seen several since then, that have even brought question to the relevance of LTT testing. One study, the one that came out in July last year, looked at patients who had had knee and hip replacements, were presenting with symptoms consistent with sensitivity and reaction to the metal. They tested them with LTT testing, and they found them to be highly reactive on LTT test. So they went back in and revised those joints and replaced them with a joint that didn't contain that metal. At the same time, they took tissue samples from around the joint. In the control group, patients having joint revisions for other reasons other than suspected hypersensitivity, they sampled tissue from around those joints too. And what they found was pathologically, to several different pathological assays, there was no difference. And so now we're questioning, is even an LTT test an appropriate test? Is it relevant? If you think about the Stryker TMJ Concepts device, it's just the condylar head that's cobalt chromium. The most common metal allergy is nickel. The component of nickel in that condylar head is 1%. So is that clinically relevant? And so now I'm involved with a study with Emory and San Antonio, Texas, looking at is someone with a reactive LTT test, do they have different outcomes with that device in place than someone who doesn't display any hypersensitivity on LTT testing? So right now, the recommendation is LTT testing, but that may change a year from now based on what's emerging in the orthopedic literature and what we hope to show in our study.
Just to add to that, there is no standard in orthopedics or in oral and maxillofacial surgery for testing every patient before you put an alloplastic device in. The testing of patients in orthopedics before putting in devices is zero. No one does. I mean, at Rush, there are 5 operating rooms operating every day, putting total joint replacement devices in. None of those patients, unless they have a documented history of metal allergy, particularly things like jewelry. You know, women will tell us they can't wear jewelry because their ring finger turns green, or when they put earrings, earrings in, they turn green. those patients can get tested. But the other thing that has come up is that one of my colleagues has studied patients with positive LTT testing that have hips and knees that are working properly. They have no problem. And he did LTT testing on those patients. And he got positive results. He got reaction to the LTT test. And the reason for that was that the patients were shedding ions and metal particles. Because even a working joint will shed those particles. And that was picked up by the LTT. So he went on and he studied patients coming back from the Iraq War, soldiers that had shrapnel in their body from being hit with bullets and things. And the bullets or the piece of shrapnel was still in the body. They were positive for the LTT test. So as Dr. Warburton says, you know, what's the value of the LTT test? We don't know. Patients with tattoos came back positive with the LTT. Patients with piercings came back positive.
Implants, so dental implants?
No, we haven't seen that because titanium is not something that reacts to today. Now, what we're seeing is that there are some patients that are sensitive to the vanadium in the titanium alloy, because it's titanium, vanadium, and aluminum. And that's the reason there's a push now towards creating a titanium alloy that doesn't contain vanadium. But that's a very, very small number of patients. And there's been, you know, in our study where we looked at the amount of metal ions in the blood, one of our test groups were patients with more than 5 dental implants. And they were off the chart in terms of the amount of titanium that we picked up in their blood. And that's natural because you would think you're chewing on these devices, they're going to shed titanium ions. But titanium itself is not a problem. It's cobalt that's the problem. And as Gary said, the nickel is a problem for hypersensitivity. So I mean, we could go on for hours talking about metal and metal hypersensitivity. And maybe at some point you'd like to hear about that and get us both back.
Sure, we would love to have you back for every possible occasion. Thank you so much. Thank you so much, everyone. It was an amazing session. I'm sure a lot of us learned a lot and we will be better surgeons and clinicians henceforth. Thank you so much, gentlemen, for accepting my invitation. Wishing you all the very best in all your future endeavors and continue to enlighten us with your knowledge and experience. Thank you.
Thank you.
Thank you.
Namaste to everyone.
Yeah.
Gary, while you're on, I will get together with you and Scott about the meeting in Tucson.
Okay.
We'll see how it goes.
Yeah. Okay. Well, we've got plan B in place. So
All right.
we'll be okay. All right. Thanks, Luke.
If we could do it video, that'd be great.
Okay. I will reach out to Scott.
All right.
Take care, everyone. Bye-bye.
Bye-bye.
Bye.